Welcome to Learning Thursdays. I am Patty Corbett Ward and your host for this presentation. Before the presentation begins, I would like to remind you of a change in Learning Thursdays for the year 2017. This year is the year of ethics and is the focus of Learning Thursdays, in that each month you will be offered a core concept of ethics as developed by the OASAS Counsel's Office and presented by Tricia Allen and Maria Passeri. As a side note to you, there will be months where there will be 2 Learning Thursdays presentations, as there are other presenters lined up to present their information and topics as well. That gives you more opportunities for new information and additional recredentialing hours. As always, I would like to do a cursory overview of the Learning Thursdays educational series. A goal of Learning Thursdays is to support and help advance the educational and professional competency development of the treatment, prevention, and recovery workforce. A competency being comprised of knowledge, skills, and attitudes relative to a task. In part, we do this by offering monthly presentations that highlight content and topic areas that are current and relevant to our field. As always, any questions, please feel free to contact us at the mailbox listed on the slide. If you have any suggestions for a topic you would like to learn about, feel free to submit that as well. And if you're interested in providing a Learning Thursday, feel free to reach us at the same mailbox. This month is sexual misconduct. As I noted earlier, Tricia and Maria are here to talk to you about that. And at this point, I would like to hand it over to them. Enjoy your presentation. Ladies, thank you for joining us.
Thank you, Patty. So we would like to welcome you to the second session for this year of Year in Ethics. Today we're going to be focusing on sexual misconduct. My name is Tricia Allen, and this is my colleague.
I'm Maria Passeri.
So what we'd like to do today is we'd like to run through the objectives for the program. So the objectives for the Learning Thursday today are to understand the legal and ethical prohibition against sexual misconduct and boundary violations. We recognize that this is not only a ethical consideration, but there is also specific laws that were recently implemented around 2013, which are also related to sexual misconduct. We will also discuss steps that an addiction professional can take related to a counselor case study and list issues that can make an addiction professional more vulnerable to taking part in sexual misconduct. And then we'd like to offer you some prevention measures a counselor can take to avoid sexual misconduct with a client. So some basic level setting. We're going to be talking about sexual misconduct from 2 different lenses. So there's the first, which is the legal consideration and sexual abuse. And that is specifically inappropriate touching, indecent exposure, sexual assault, sexually explicit pictures, either taking or distributing them, or other types of voyeurism or sexual exploitation. And then there's misconduct, and that's entering into any type of exploitive or sexual or other intimate relationship with a patient or a former patient or a service recipient or their significant others that's outside the boundaries of professional conduct. So in the first session for Year in Ethics, we did do kind of an overview of mandatory reporting, and it covered a lot of the New York State Justice Center. So I'm going to do just a really quick overview for this session. So a couple of basic tenets. The Justice Center has jurisdiction for incidents of abuse or neglect that occur in OASAS licensed, certified, or operated programs, and they accept all reportable incidents, so that's significant incidents as well as abuse and neglect. Now, one thing that I did want to point out, when we talk about Justice Center specific incidents, we're talking about incidents that occur or are committed against a vulnerable person, and that's someone that, due to physical or cognitive abilities or their need for services or placement, are receiving services from a facility or provider agency. Now, I am going to just warn you up front, I do kind of switch between vulnerable person, service recipient, and patient pretty regularly. So please know that those are all the same person, but just be aware. So a couple of really quick definitions. Types of abuse and neglect. We've got physical abuse, so that's hitting or kicking or shoving a service recipient. Psychological abuse, that would be taunting or name calling or making threats towards a person. And then sexual abuse, and that's inappropriate touching, indecent exposure, the list that we had discussed earlier. And then neglect, and that's failure to provide supervision, adequate food, clothing, shelter, healthcare, or access to educational entitlements. Another type of abuse and neglect is deliberate misuse of restraint or seclusion. This is not something that I think we see a lot in our program specifically, but this is just the use of interventions with excessive force or as punishment or for the convenience of staff. And then controlled substances, which is using, administering, or providing any controlled substance contrary to law. And then aversive conditioning, which is unpleasant physical stimulus used to modify behavior without person-specific legal authorization. And then finally, we talked, I think, a bit more at length in the first Learning Thursday about obstruction, and that's interfering with this discovery, reporting, or investigation of abuse, neglect, falsifying records, intentionally making false statements. Okay. So in addition to abuse and neglect, we also have significant incidents, and that's an incident of some sort that could result in or has the reasonable foreseeable potential to result in harm to the health, safety, or welfare of a service recipient. And that can be conduct between service recipients or conduct by a custodian against a service recipient that's inconsistent with their treatment plan, but is not as severe as a case of abuse or neglect. A couple of other things to be aware of. Significant incidents can also include a crime, a missing client, a confidentiality violation, actual suicide attempts, or body cavity searches. Real brief review again. In order to report abuse and neglect, it's when there's reasonable cause to suspect that a service recipient has been subject to a reportable incident, and you can make a report to the VPCR online hotline or to the web intake form. So anyone who has regular and substantial contact with a patient is a mandated reporter. And a custodian, which is one of the mandated reporters, is a director and operator, anybody who works at the facility as an employee or a volunteer, a consultant who works at the facility, or an employee or volunteer of a corporation or organization that provides goods or services to the facility or provider agency pursuant to a contract. And again, one thing to consider there is it's got to be somebody who has regular and substantial contact with individuals who are cared for by the facility. In addition to custodians, there's also human service professionals, and these are all mandated reporters, and that includes this extremely long list of human service professionals, which I'm not going to list all of them, but essentially anyone with a license. You'll see physicians in there, mental health professionals, peace officers, police officers, district attorneys. Okay, so the legal and ethical prohibitions. Obviously, we take this matter very seriously. We're here to speak to you about it today because we think it's so important that we have an open discussion about the need to address and recognize the importance of addressing boundary violations and sexual misconduct, especially when it's involving individuals that come to us for help in achieving and sustaining recovery. So this is a brief outline of the legal and ethical prohibitions, and then I'm going to turn it over to Maria, and she'll talk more to the clinical aspect. So specific statutory changes that came through with the Justice Center that is specifically targeting abuse and neglect by a caretaker. Where this starts is inappropriate relationships between counselors and clients. It may be that they're Facebook friends. It might be that the counselor brings, candy to a service recipient, or maybe lets them watch TV for longer than, the others, maybe late at night, exchanging phone numbers or texting, dating, taking a client to your home unscheduled private meetings, off-schedule unnecessary contacts, or some sort of extraordinary help, giving gifts either by the service recipient to the addiction professional or from the addiction professional to the client. So that's where abuse and neglect, or specifically sexual misconduct, can start. And some of these seem somewhat benign, but can quickly escalate. So we wanted to just offer you a couple of examples of where we've seen that these circumstances can start. So something to be aware of, there were some statutory changes in 2013 with the enactment of the Justice Center, and that included changes to the penal law that provided or expanded the statutory rape provisions to incorporate certain vulnerable persons. And vulnerable persons would include individuals receiving services at OASAS, licensed or certified funded agencies. So for non-residential facilities, the victim must be a client or a patient of that facility, and it's a very specific list of actors. So it's got to be a healthcare provider or a mental health care provider. So healthcare, that would be a physician. Mental health care provider, we're talking about an LCMSW, LCSW, yes, LMSW, as well as, nurse practitioners, et cetera. So the offense has to occur during a treatment session, consultation, interview, or examination. However, I will say in, being privy to some of the cases, speaking with the Justice Center, seeing some of the trainings, it does have to some degree a level of whether or not the client or the patient believes that they are in treatment. So while it may not be from the actor's perspective that they are in treatment, if the client believes that they are in treatment, then that counts. So a couple of the specific offenses include rape in the third degree, a criminal sex act in the third degree, sexual abuse in the third degree, and then aggravated sexual abuse in the fourth degree. So these are essentially penal law 130 offenses. And then here's a slight difference. For residential facilities specifically, the actor is anyone actually in the program. So the victim has to be the client or the patient, and it has to be an OASAS facility, although I will say OPWDD and OMH facilities are also incorporated into this, but I'm only speaking to OASAS perspective specifically. And the individual who is committing the sex offense is any employee of the facility. It's not limited to some sort of healthcare professional. And it would be any Article 130 offense again. So rape, criminal sex act, sexual abuse, aggravated sexual abuse. Oh, okay. So one thing that I would like to point out is what I specifically lined out just now are the criminal offenses, which can lead to criminal prosecution, and I would like to very much differentiate that between any type of administrative finding which the Justice Center may make, or any type of ethical finding which OASAS may make, especially where we have given an individual a credential. So part of that is understanding what can happen through the administrative process where someone has committed some sort of sexual misconduct or sexual abuse against a client. There can be a Category 1 substantiation, and that is a severe abuse and neglect with some sort of intentional or reckless or knowing component to it. Category 2 is going to be conduct by a custodian in which the custodian endangers the health, safety, or welfare of a service recipient. One thing I would also like to point out is there may be circumstances where an individual doesn't fit the definition for sexual abuse, Category 1 sexual abuse, but they may still, based on the actions they've taken, fall within a category of neglect against the service recipient. And then Category 3 is abuse or neglect by a custodian that's not otherwise captured by Category 1 or 2. It's kind of a catch-all. And then Category 4 determinations, those are systemic problems in the facility or where they're not able to identify who the perpetrator is. So this is going back a little bit to where I was offering a differentiation between the two, or the the different penalties that could occur where anyone committed sexual misconduct or sexual abuse against a client. Again, criminal prosecution is absolutely a very real possibility. There may also be, in addition to criminal prosecution or separate from, placement on the staff exclusion list, which prohibits an individual from being in an SOA, a state oversight agency's program. So that would include any of the 5 SOAs. And that can occur when there's a Category 1 finding or if there's 2 Category 2 findings within 5 years. Employment actions, so that could be any type of suspension, termination, as well as, again, impact on your professional license or your credential. So I think I touched on this a little bit in the original taping, but I will reference it again. There can be criminal liability for failure to report by a custodian or a human service professional where you see an incident of abuse or neglect. So if you fail to report to the Justice Center, you can be found guilty of a Class A misdemeanor under the Social Services Law. Obviously, it has to be an intentional act, but it is a possible additional penalty. And then there may also be civil liability that follows from that same failure that's knowing and willful to not to report a suspected case to the Justice Center. Okay. So some ethical considerations, and this is speaking more towards individuals who are licensed and or credentialed by OASAS and or state education department or any other licensing agency. So New York State OASAS is the oversight agency for credentialed alcoholism and substance abuse counselors, or CASACs, credentialed problem gambling counselors, or CPGCs, and then certified prevention practitioners, and those are CPPs or CPSs. And then, just be aware, a CASAC or other OASAS credentialed person who has engaged in sexual misconduct or sexual abuse, that is absolutely an ethical violation. It is absolutely subject to and will be investigated by OASAS credentialing, and there will absolutely be some credentialing action taken against your CASAC or CPGC or CPP or CPS. So just as a reference point, we all have a canon of ethics if you are licensed or credentialed. Specifically for CASACs, there are specific provisions within the ethics, within the canon of ethics that prohibits counselors or CASACs from engaging in relationships with patients, former patients, their significant others. The concern is the risk of exploitation or potential harm to the patient. Obviously, when you are a CASAC and you're working as a counselor with an individual who suffers from a substance use disorder, you are in a position of inherent power, and we are very aware of and concerned about that, and that is why this is one of the items that is covered so intensely, I guess you could say, through the canon of ethics, is we do want to very much protect that counselor-client relationship to ensure that it is therapeutic and helpful to them during their recovery. Some other provisions specifically speak to a prohibition against any sexual activity with current or former patients or their significant others, as well as knowingly engaging in behavior that is harassing, demeaning, and that's including sexual harassment, but is not limited to. There are also specific provisions within the CASAC canon of ethics which states that it is misconduct to enter into any type of exploitative, sexual, or other intimate relationship with a patient, a former patient, or a significant other that's outside the boundaries of professional conduct. So when we talk about an intimate relationship, I want to kind of define the scope of that. So an intimate relationship, it means a relationship between a person not related by consanguinity or affinity, so not by blood or marriage, regardless of whether that person lives together at any time. There are a couple of factors that can be considered in determining whether a relationship is an intimate relationship, and that can include the nature or the type of relationship, and that's regardless of whether it's sexual in nature. the frequency of the interaction between the persons, and the duration of the relationship. So that kind of gives you an idea of our concern and what we are speaking to when we're saying that it's inappropriate for an individual to engage in an intimate relationship with a client. Okay. So another thing to consider is the CPGC professional code. Again, it covers prohibition against engaging in activity with any patient or former patient or their significant other, as well as engaging in behavior that's harassing or demeaning. And there is an absolute prohibition against exploitation of patients, with the recognition that we have as a professional a position of authority over that individual. Similar provisions are included in the CPP or CPS canon of ethics. Do no harm to service recipients, and then the practices shall be respectful and non-exploitive and protect the service recipients from harm and the professional and the profession from censure. There's also a mandate that you maintain an objective, non-possessive relationship with those that we serve and to not exploit them sexually, financially, or emotionally. Similar themes come out in multiple different fields. So this is the AMA Code of Medical Ethics, and this is Opinion 814, which is sexual misconduct in the practice of medicine, and speaks to the inappropriateness of sexual contact that occurs between concurrent with the patient-physician relationship. And there's also the prohibition against sexual or romantic interactions between physicians and patients because of the fact that it can detract from the goals of the physician-patient relationship and could lead to exploitation and vulnerability within the patients. The Social Work Code of Ethics also speaks to sexual relationships and sexual harassment, and it prohibits sexual relationships with current clients regardless of consent. Sexual contact with former patients or clients is also prohibited because of the potential for harm to the client. And sexual harassment is also prohibited. Under the Nursing ANA Code of Ethics, professional boundaries states that dating and sexually intimate relationships with patients are always prohibited. So that's just a run through of a couple of different codes of ethics that you can find where there's a common theme of a prohibition against inappropriate sexual relationships and or contact with patients, clients, service recipients. All the same word, really. So now I want to turn it over to Maria, who's going to speak more to the practical considerations.
Okay, thank you, Tricia. After all the information that we have on ethics, the codes that we have established for each one of the professional areas, and the training that we're having today, we still have quite a few incidents of sexual misconduct within our field. And why is that? Why is it that people can't follow the code of ethics? And that's been a question for the administrators of many programs throughout New York State. And really it goes beyond the code of ethics, and it really gets down into understanding the counselor and or the healthcare professional and the patient and the dynamics that happen between that relationship. And in counseling, the basis of all of our work is the therapeutic relationship. And so sexual misconduct and sexual interaction compromises the therapeutic relationship. So if we take a look at that, sexual conduct involves some sort of fantasy initially and some regressive thinking, and counselors are unable to be grounded in the therapeutic role. They have a major role in guiding someone's recovery, and that is an interfering factor in establishing that relationship. Also, sexual contact between counselor and the client does not permit the counselor to fulfill the ethical duty, and their ethical duty is to attend to the treatment needs of the patient. And that's where that's compromised. And sexual contact breaks down the therapeutic relationship, and it's contrary to maintaining the counselor authority. So in the case of the counselor being the guiding person here that continues to compromise that piece, and recovery is not the focus. And that's what the patient came into the particular program for. There are many dynamics when we take a look at counselor and patient boundary violations. The first one is exploitative. The counselor, whether it's conscious or not, places his or her interests or wishes ahead of the client's treatment and well-being. And those individuals who are conscious of it have a particular category that we'll talk about later in this presentation. But oftentimes, this is something that is unconscious. Also, there's role reversal and misplaced desire to help. We have to remember that counselors have vulnerabilities. They're people, they're humans, they have their own private lives, and they can be vulnerable due to their age, illness that they may be bereaving, involved in a divorce, or other personal losses. And so this is oftentimes when a counselor is going to confide to the patient about personal matters. And again, switching that role, because now the counselor is in the role of needing assistance versus the patient who came into care to establish their recovery. And third is the rationalization that's used when counselors who justify their conduct by saying that the patient is competent to make his or her own decisions. And that's one area, I think, in the chemical dependency field that we have difficult understanding, that our population is vulnerable, and the substance use disorder affects a person in all different aspects of their life, and so they are a vulnerable population, and engaging in any sexual misconduct with them is contraindicated. This next slide is very interesting, and it was a study that was done with 585 psychologists. And I think that it's important to talk about it because it is the reality, and we have to understand that reality if we're going to do any kind of preventative interventions. So first of all, it's normal for counselors to either be attracted or repelled by their clients. And we all have instances where we can talk about clients who make us angry, clients who are difficult to treat, who are relentless and make it very difficult to run your program because of the symptoms and behaviors of their disorder. So oftentimes we understand that piece, but on the opposite side is there could be some sort of attraction there.
And if I could just cut in.
Yes.
One thing that I think that we see a lot is, the counselor who's working with a client who, for whatever reason, they get really invested in that person's recovery, and they really connect with that person, and they really feel that they're helping them. Mm-hmm. And then it kind of slides into a different realm or maybe crosses a boundary. So it almost goes from so invested in helping them and seeing them succeed in recovery and reach a solid foundation, and then it kind of goes beyond and kind of turns a little. So mm-hmm. I think I just wanted to point that out, because when we talk about sexual misconduct, it's so important to recognize that there are circumstances where that is not the intention that the person started out with. They may have started out, very much focused on helping individuals, but at some point they crossed the line. They went from being a counselor to being someone who's committed misconduct or illegal conduct right. in some way.
Right. And with that, just like we know relapse doesn't start with using. There is a long process with relapse before we actually get to using the substance. Mm-hmm. And that's the same thing with sexual misconduct, and why we talked about in the earlier slides being Facebook friends, having more contact than necessary. All those different things occur throughout the treatment episode that begin to establish a different relationship there, and then the ability to cross the boundary. Mm-hmm. And so that's why it's very difficult to just adhere to a code of conduct, because it's a long system before it actually hits
Starts
into
with the candy
action.
jar on the desk, and then it gets to
Exactly.
you confide with the I notice you have a picture of Hawaii on the back of your wall, and that sounds great, and then the conversations can turn and the interactions can change.
Absolutely, absolutely. So in taking a look at this particular study, 87% reported that they had been sexually attracted to their client. 63% said they felt guilty or anxious or confused about those feelings. And in another national survey, 46% of counselors have reported occasionally having sexual fantasies about a client. 26% had frequent sexual fantasies. And the actual perpetrators make up 4.4 of our counselors. And looking at the incidents that have occurred over the last 3 years since we've been involved with the Justice Center, that seems to hold true, that there is still a small percentage of the people who come into our field that are definitely perpetrators. And in that, the mix is 7% male and 1.5 female. So how do counselors refrain from acting on feelings? First of all, there have to be a recognition of those feelings, whether they're an attraction or a revulsion, because the revulsion can also interact in a way that the counselor is going to not talk therapeutic to the patient as well between the counselor. And then that these occur naturally because we're human. And so if we have that recognition, then that opens up the supervision session to talk about it. And that's what we want to have happen, to understand that it does occur naturally and that we need an opportunity and a place to talk about it. And supervision is probably the most important aspect that we do as program supervisors and administrators. And it's oftentimes the one activity that we do not spend enough time on.
And I'd actually like to cut in here because I think that this is so important for us to stress. You'll hear us time and again throughout all 12 months of this experience referencing the need and the importance of clinical supervision and speaking with your supervisor. And the reason that we are so focused on that is, like we said, this doesn't start immediately with the decision to engage in sexual misconduct. This starts with the client who, for whatever reason, can just get under your skin, or who has a unique knack for frustrating you, or the client who, for whatever reason, you are very invested in seeing their recovery, and you eventually get to the point where you cross the line. So that's why we are encouraging and focusing so much on clinical supervision and speaking with your supervisor early and often about any concerning feelings that you have, positive or negative, strong emotions that you have and responses that you have to clients. Because as the person in the role of power, in the position of power that you hold as a counselor with these individuals in early recovery, it's important for you to recognize your impact on that individual going forward.
Okay, thank you. Also, recognition when you're unable to work with a specific client, and special attention to addressing the client's feelings of rejection before and after a transfer. So if you are having difficulty with a patient, whether it's positive or negative, recognizing that, talking about it in the supervision session, and making a plan. So if we're going to transfer the patient to another counselor, then we need to make sure we do it in a way that the patient doesn't feel responsible for that action. The third, as we talked about, supervision, supporting the counselor in maintaining or recovering a professional, ethical, and clinical perspective. And one thing that we're doing in the New York State Addiction Treatment Centers is the documentation of supervision. We're using a specialized form that was presented to us through CARF, which is our accrediting agency. And I would be happy to share that. You'll have my email at the end of this presentation. And if you're interested in that supervision form, it involves a lot of different aspects of supervision, one being ethics, so that ethics is discussed because it's there as a reminder and a place for that relationship between you as a supervisor and the counselor can have these discussions. And last but not least, really, you want to be able to initiate personal therapy if in fact you can't seem to go to your supervisor or talk about it, for deeper exploration of feelings that are difficult to discuss in supervision. What we do know is there are harmful effects to sexual misconduct. And in a published national study of 958 patients who had been sexually involved with a therapist, we saw that 11% were hospitalized, 14% attempted suicide, 1% committed suicide, 10% had experienced a rape prior to the sexual involvement with the therapist, and about a third had experienced incest or other child sex abuse. And 5% of these patients were minors at the time of sexual involvement with the therapist. And of those harmed, only 17% fully recovered. And so the harmful effects isn't just the act in and of itself, but it is lifetime for people. And we know that through understanding PTSD in our patients, and many of our patients experience post-traumatic stress disorder, and that it takes a lot of therapy and care and understanding to move past that.
And I do want to speak a little bit to the harm as well, if I could just cut in. Nowadays, when we're talking about individuals who are being harmed, we are currently in an epidemic that I would say is very scary. We have heroin, and we have opioids, and we have fentanyl that is becoming more and more prevalent, and overdoses and deaths from those substances are more and more prevalent. So when we talk about patient harm, to any extent that you try and rationalize it, there is a very real consequence that's going to come from this, or could come from this, and that is where the client ends up leaving treatment and overdosing and possibly dying.
So there are some common reactions to counselor-client sex. And I wanted to review these because these are things that happen for our patients as a result of sexual misconduct. First being the ambivalence. The client is really caught between two sets of conflicting impulses. So on one hand, they want to escape from the abusing counselor and this destructive relationship, but they also are seeking to break the silence and seek justice. So there's this conflict for them, and what's important to understand is that people take a long time to disclose that information, and we saw that with the clergy, that oftentimes the sexual misconduct of clergymen, many individuals stayed silent for many, many years to protect that particular person. Meanwhile, they were suffering the harmful effects of that relationship. And on the other hand, they also want to protect that person at all costs, because that person is adept at creating a very nurturing environment for the person. And so that's what we refer to as grooming, so that it makes it very difficult for the client to report that person, because the person is doing so many good things to that client that they feel like they're betraying that person. Also, our patients experience cognitive dysfunction. A client may experience interference with their attention, their memory, and concentration. These are all symptoms of post-traumatic stress disorder. In addition, they will experience intrusive images, nightmares, and flashbacks. And oftentimes that's kicking up some of that child or sexual abuse that's happened to them in the past with others. They also have an impaired ability to trust. That in our counseling relationship, as I talked about in the beginning, is built on exceptional trust. So if they've been hurt by a counselor before, then they're more reluctant to engage in working with a counselor moving forward, because they can't trust that they'll be cared for in a good way. Also, they feel guilt. Clients who become sexually involved with a counselor may be flooded with persistent and irrational guilt, thinking it's their fault. And for women in particular, they're programmed to take responsibility, and they feel guilty about relationships and that it's their interactions that have caused sometimes those difficulties. As well as women often feel they have done something to cause the seduction. And so those feelings of guilt continue to plague that client. And they also have increased suicidal risk. And research indicates that 14% will make one suicide attempt. So that's 14 individuals per 100 clients make an attempt due to sexual misconduct of a counselor. Also, there's role reversal and boundary confusion. Counselors who sexually exploit tend to violate their roles and boundaries in treatment. So the focus of the session goes from the clinical needs of the client to now the personal desires of the therapist. And the harmful effects of this violation can persist long after termination of the patient and sexual relationship. And we know that based on the information we received that 17% recover. So that means a majority of people do not feel recovered as a result of this. Also, emptiness and isolation. Clients may experience a sense of emptiness and a sense of self that's been hollowed out, and they feel cut off from a social bond with other people. And so those are the common reactions to the counselor-client sex. Vulnerabilities are very interesting, and there's 6 of them here. And the question is, what makes a counselor more likely to engage in a serious boundary violation? And in the cases that we've had within our own system, we always ask that question, why this person? Oftentimes we're stunned or shocked by their behavior. And so there's really 6 types that are listed here. First and foremost being the inadequately trained or inexperienced counselor. They lack professional ethics. They sign off on the code of ethics and they have no understanding of the dynamics that will happen once they begin to get a caseload, begin to establish a relationship with the client, and all of them want to do the best for their patients. So they are very committed in working on that relationship, but yet they don't understand that sometimes overcommitment can result in boundary violations. There's also the counselors that have just a bad moment in their life. So they're involved in a divorce. They may have had a death in the family, and they're feeling very vulnerable. And the patient is being very nice to them and caring for them, and so that's where that dynamic begins to change. There are also counselors that we have in our field, as we know, that have severe problems, mental health problems, with depression, feelings of inadequacy, low self-esteem, and social isolation. This puts a counselor in a much more problematic situation because oftentimes they're going to seek their comfort from the program and the patients that they serve. And then we have counselors who have severe behavioral disorders, poor impulse control. They act without the appreciation of the consequences of their behavior. So these are individuals who need maybe an EAP referral. You should be seeing some sort of behaviors that manifest in their work day to day, and these are the issues that should be addressed in supervision when we sit with them. And we want to make sure that we have a plan of action, because oftentimes these are the prerequisite things that happen to the counselor that end up in a serious boundary violation much later on. And last but not least, that 4% of the population, there are counselors who are deliberate and calculated, highly skilled at manipulation. They give the appearance of propriety and they maintain their professional reputation. So these are the perpetrators. These are the ones, the small percentage that have gone out and actually hurt the client knowingly. Now, there's a different aspect that we wanted to address because our patients are also vulnerable, and we're providing a lot of care and nurturance to them while they're in treatment. So oftentimes they will approach us. So the next portion of this training is around when a client initiates sexual advances. And so it's well documented in the literature that a client's love for a counselor can also occur in the counseling relationship. We're doing a lot of things to help our patient, and so they're often very grateful for that help, and they feel very attached to us because of the work that we do with them. Most of our clients also are predisposed to be cooperative with us. Even though we've had people who are difficult to deal with, many are very cooperative. They feel completely dependent or compliant with a particular counselor. So because they're coming in with a lot of needs, we seem to have the answer for housing, for medications, for unloading some of the things that have happened in their lives. They're starting to feel better because they're having some time and distance away from their substance. And so they are feeling very good about that relationship that they have with you. They also may perceive you as a romantic idol who will rescue them. They also can see you as a nurturing parent substitute for whom they have always longed for. They can see you as their savior, the person who can cure the client, and the flawless counselor who knows and understands all. And one of the things we have to remember as counselors is we can't get caught up in that we're the savior and that we're the best thing for that client, that any of the team members provide that care to that client, and that you can't be everything to them. And so it's really important to know that the recovery work starts with the patient. We're only guiding the process and giving them some information so that they can make informed decisions for their recovery. But we cannot get caught up in the fact that we are the person and the only person who can handle that particular patient. So the first thing I'd like to look at is the counselor's role in addressing this. And we want to take a look at doing it in a way that, one, becomes knowledgeable to everyone on your clinical team, as well as making sure that it's documented in the chart. So a counselor can respond to a client's sexual advances most effectively with a straightforward, compassionate limit setting, reminding the client that this type of relationship contradicts the purpose of counseling and treatment. Also, when a client persists in making sexual advances, it is the counselor's responsibility to maintain the limit setting, and I can't emphasize that enough. It is your responsibility as the counselor to maintain that limit setting and remind the client that the counseling relationship will no longer be effective if this continues. And it's important at that time then to seek supervision and make further treatment interventions and making some decisions about maybe transferring that particular client to another counselor, and doing so in a way that still is very person-centered and caring.
So one thing that I will say is it is absolutely important, I think both clinically and programmatically to ensure the minute that you experience any type of circumstance where a client or a patient may be making any type of advance, that is clearly documented as quickly as possible, and that you do speak with your supervisor about that so that they are aware, so that you can make sure that you have identified that it is an issue and have identified a plan to address it with the client so that they know what the boundaries are and so that there's no impairment to the counselor-client relationship.
Thank you. It also can move to coercion and blackmail, and we've seen that in a lot of programs. Despite the preventative limit setting that we do and the redirection that we do, clients will escalate through blackmail. They may threaten suicide. If you won't have a relationship with me, I'll just kill myself. It's not worth living. They may do some self-mutilation and getting cutting behavior. They may disrobe. They may sabotage the counseling, and/or they can make false accusations of sexual misconduct because they're angry and they want to retaliate in some way. When a counselor is threatened by a client, responses must address the issue at hand and bring the focus back on the client and the therapeutic response to the threat made. So it's really important that we begin to restate the therapeutic relationship and the focus of the counseling, and if that can't be made, then we have to continue to decide how that patient might be handled. And that should be done with supervision as well as administrative feedback. It's important to document the threat made to the counselor in the case record with the clinical response from the counselor. So what was the threat and what kind of things did you say to the patient? That should be documented. Report the accusation to the clinical supervisor for further direction, always, and consider requesting advice from the licensing board without using a client's name. So you can go back to the state education department if you're a nurse or a physician or a social worker, or you can seek some sort of information from our credentialing unit with OASAS. But it's important to make sure that we document it because then that is helpful as the case moves forward. So there's some lessons for dealing with difficult clients. Good intentions are not enough, we know that. The impact of the client must also be considered. What the counselor intends and how the client perceives it may be very different. And I often tell counselors we have to hear what the patient perceives because that's the reality of the situation. And while your intentions were very good, this is the information that the patient received because it's filtered through someone who isn't well yet and who still needs to deal with the issues of their recovery. Also, as I've talked about before, a series of benign boundary crossings may leave the impression that something is wrong. And so we have to take a look at what is going on. Is there more time being spent with one patient? Is a counselor going in a patient room that's it's not necessary to be in? Mm-hmm. All the different things that we can take a look at and prevent the situation from occurring.
And I think that's a very important thing to recognize as the supervisor or the executive director or clinical director, that the people who are kind of overseeing the program and have daily interaction with the staff as well as with the clients, is recognizing that, you know, there may be one particular person who the clients seem to flock to, or maybe there's you know, a lot of meetings happening between a particular client and a specific counselor, or there may just be a specific client drawn to a counselor more than any other, but in an appearance of a non-therapeutic way.
Exactly.
Yeah.
Always clearly document your clinical rationale when providing interventions for your client. And consultation and clinical supervision are of critical importance. The other area that I think is important is the multidisciplinary team or case conference that you have. Oftentimes that's a group of individuals who's dealt with the client as well. Oftentimes our colleagues have a more objective view of what's going on for the patient and what's going on for you. And hopefully if it's a good clinical case conference, you're able to talk to each other, provide feedback to each other that's really helpful for one, maintaining the counselor, maintaining their particular boundaries, as well as nothing happening to the patient that would be misconstrued as misconduct. So the last thing is that the counselor is responsible for limit setting and maintaining boundaries. Even if the client threatens harm or flight from treatment, we have to maintain the boundaries at all costs. Some important concepts to remember. Sexual relationship with a client is incompatible with any form of professional addiction treatment and therefore is always unethical. Establishing an effective supervisory relationship in an open, healthy environment where staff are encouraged to have clinical discussion and exploration of counselor and client feelings. Recognizing and examining his or her own sexual feelings towards a client, a counselor is better able to accept and explore the client's feelings in a way that's neither exploitative nor punitive. And a counselor can respond to a client's sexual demands most effectively with straightforward, compassionate limit setting, reminding the client that this type of relationship contradicts the purpose of counseling and treatment. And even when a patient escalates to threats and blackmail, the counselor maintains responsible for setting and maintaining the boundaries. And as I said before, if you're interested in any further information from Tricia or myself, here are our emails, and we would be happy to help you. Thank you.
Thank you.
Thank you, Maria and Tricia, once again for joining us for Learning Thursdays. And we will see you back here in March with another topic under the Year in Ethics for 2017. Thank you. Folks, again, if you have any questions, feel free to email us at learningthurs@oasas.ny.gov. And please notice, too, that we have returned the SurveyMonkey link, and we would appreciate if you would take a few moments to fill that out. It really gives us feedback on how you viewed the presentations, if they were helpful to you, and what you would like to see in the future. That being said, ladies, thank you. Thank you for joining us, and we will see you in March. Bye now.